Good morning to all. So, in the middle of second or third wave, we don't know. So there another topic which is dedicated to COVID-19, which has a very bad prognosis. That is COVID-19 associated acute kidney injury. So I'll be covering my topic in this following outlines, right from the one interesting case report to the renal replacement therapy, then the planning of the finite resources. Then we have our own data, and finally the summary. So this is a case report of a 70-year-old male who has a comorbidities of hypertension, diabetes, and old MI almost 10 years back, or hypertension 20 years, diabetes 15 years, and MI 15 years back. Chief complaint was he has a fever of 10 days with gradually progressive shortness of breath. Patient was admitted outside on 8th of September on oxygen support on nasal prong. Later on, patient was converted on the high flow nasal cannula for oxygen delivery. His baseline investigation showed outside reports that hemoglobin of 13.2, creatinine of 1.1, TLC count is little bit high of 18,000, but COVID-19 report is negative. But chest X-ray showing pneumonitis, suggestive of pneumonitis, these are all outside reports. And later on, patient was shifted to AIIMS Jodhpur on 12th of September. Now, if we see here, patient admitted on 12th of September, his hemoglobin is 13, counts is a little bit decreased from 18,000 to 14,000. Serum creatinine from 1.1, it rose to 3.0. He was admitted and chest X-ray here was done. It is also showing pneumonitis. Patient was admitted in the suspect ward, and his report came out to be COVID positive. He was shifted to COVID ICU. Now, as you see here, hemoglobin is dropping and serum creatinine is increasing. TLC count is also increasing. In view of this and hypotension, patient was intubated and vasopressors was started. Later on, patient urine output also decreased and patient was initiated on the HD. Now you see the TLC count, it remained high from 32. Some antibiotics were added here, cultures were sent, it came down to 16. Again, it came down, rose to 20.93, and patient was expired on 24th September. So based on this case report, my talk is based on the risk factors and the management, which I will explain later on. Now, as far as introduction is concerned, initially AKI was reported less, but now it is recognized as a common complication of COVID-19 and is definitely associated with adverse outcomes. COVID-19 associated AKI is more prevalent in the intensive care units because patient needs intubation, vasopressors, etc. The reported rates of AKI are extremely variable in different countries. However, available evidence suggests that it likely affects more than 20% of the hospitalized patient and 50% of patients in the ICU. ICU admission, this is somewhat important, that 40 to 60% have AKI and 20 to 30% definitely required RRT. Now, if we see the data from the different countries, you just see here, early reports from China, little to no AKI. Subsequently, Italy reported 40% cases in ICU and 20% RRT. From US and Europe, 20% in the general hospital and 50% in the ICU. And definitely some patients who are being discharged from the hospital, they remain dialysis dependent despite having acute kidney injury. Now coming to the pathophysiology, that is something important, but I will describe the pathophysiology in very brief. If we see this diagram from here, COVID infection, if we go here, you see endothelial damage, podocyte localization, proximal tubule localization, mitochondrial dysfunction, acute tubular necrosis. This is AKI or acute tubular necrosis are synonym, but it is a pathological diagnosis. And finally, renal failure. Second is hypovolemia, because patient generally present with very high fevers and at times diarrhea also. This is the most common hypothesis which is prevailing, that is the cytokine storm that leads to increase in the inflammatory mediators, ultimately endothelial dysfunction and multi-organ failure. If we see here that patient is having a pulmonary symptom, that patient may have ARDS, mechanical ventilation, then the complication of mechanical ventilation can also lead to renal failure. If patient is having renal failure, then definitely he will have hypervolemia that ultimately worsen pneumonia. Hypercoagulability, this is somewhat that is proven because we are giving fractionated or unfractionated heparin to the patient, and definitely it is leading to microthrombi, rhabdomyolysis, and finally AKI by different mechanisms. Now, if we divide this pathophysiology, then it is a very good diagram which is published in the Lancet, in Nature. So it has a direct viral effect and the indirect viral effect. So in the direct viral effect, virus is directly infecting the kidney, leading to proteinuria. And the pathology of this proteinuria is collapsing glomerulopathy, endothelial damage, coagulopathy, complement activation, and inflammation. Now, if you see the indirect effects, it is basically fluid management, complications of mechanical ventilation, nephrotoxins that are very important if you are dealing or you are suspecting that this case may land up with AKI. Organ crosstalk, this is somewhat theoretical. Fever, as I have already explained, and diarrhea, hypovolemia, and acute tubular injury. Now, I'll be explaining this direct and indirect effect one by one. So, direct pathogenic mechanism, histopathological data, viral tropism, endothelial dysfunction, coagulopathy, and complement activation. First of all, if histopathology is concerned, if there is one very good study of 26 postmortem study of 26 patients, which showed patient has acute tubular necrosis, acute interstitial nephritis, thrombotic microangiopathy, collapsing glomerulopathy, and renal infarction that is found in the postmortem of 26 patients. And very interesting is that they have also found a viral particle on electron microscopy directly in the kidney. So probably this has some direct effect on that. But there are two negative studies also in which they do not found real-time PCR was done on the frozen kidney tissue, and there is no evidence of direct kidney invasion. Another study from Germany also failed to demonstrate it, but the sample size is very low in this German study. So presently, this has a large sample size, and they have demonstrated ATN and AIN. Second direct effect is viral tropism. As we all know, in the pathophysiology, it has been described since long time that angiogenic pathway likely plays an important role in the pathophysiology. Interaction with susceptibility genes and manifestation, the severity like APOL1, G1 to G2, NK cell variant, and complement regulation, they are of interest. Endothelial dysfunction. Endothelial dysfunction, it is characterized by high D-dimer levels, microvascular damage, and they represent a key factor for COVID-19 associated coagulopathy. That is very important. Complement activation and thrombotic microangiopathy are important mechanism of kidney injury. However, so far these have not been established as causing AKI in COVID-19. As I have earlier told you that cytokine storm, this is the most common theory which is going on. It leads to activation of the inflammatory response that has been termed, which might contribute to the pathogenesis of COVID-19. And it leads to multi-organ dysfunction, and if this multi-organ dysfunction arises, then definitely kidneys are affected. COVID-19 results from a complex pathophysiology that involves activation of innate immune system, complement pathway, hypercoagulation, endothelial injury, which are worsened by systemic hypoxia, hypotension, and sepsis. This four lines explain the whole pathophysiology which is going on the kidney when there is a COVID-19 patient with multi-organ dysfunction. Now, some light on the indirect pathogenic mechanism. First of all, systemic effect and critical care interventions, organ crosstalk, baseline patient characteristics. Now, if we see a fluid loss, considerable insensible fluid loss might occur through hyperpyrexia because patient presents with high fevers, gastrointestinal manifestation of COVID-19 such as diarrhea, which may result in volume depletion, an important potential contributor to AKI in other settings. Similarly, critically ill patient might be exposed to nephrotoxins as a part of their clinical care, in particular antibiotics, which are most important. And at times when we have to send patients for contrast enhanced CT scan, then we have to be very careful regarding this, which can cause tubular injury or acute interstitial nephritis. Moreover, who develop secondary infections are at increased risk of secondary sepsis associated AKI. Now, this is somewhat important. Specifically, COVID-19 ARDS is often treated with PEEP, increasing positive and expiratory pressure, which leads to increased intrathoracic pressure. This is important, can ultimately result in renal venous pressure, increased renal venous pressure, and reduced filtration, which may be further amplified if intra-abdominal pressure is elevated. So we have to be very careful about this PEEP if we are using in COVID-19 patient, and definitely we have to use to some extent. In addition, all forms of positive pressure ventilation can increase sympathetic tone, leading to secondary activation of renin-angiotensin system. And as we all know, this renin-angiotensin system leads to constriction of the renal vasculature, which further reduces the renal perfusion. Now, in another indirect mechanism is organ crosstalk. Organ crosstalk describes the complex mutual biological communication between distant organs. This is important. That is mediated by signaling factors including cytokines, growth factors, as well as release of damage associated molecular pattern, which is known as DAMP, from the injured tissue. Such crosstalk has been suggested to mediate AKI in the setting of ARDS because, for example, lung injury in patient with COVID-19 can be severe and abrupt and lead to release of not only DAMP but also cytokines, chemokines, and vasoactive substances that may continue to AKI. Tissues other than lung may also serve as a sources of DAMP. For example, rhabdomyolysis in the setting of COVID-19 would result in release of myoglobin from the muscle, and that ultimately leads to pigment nephropathy and AKI. Now, baseline patient characteristics are somewhat important because available evidence suggests that older age with different comorbidities like diabetes, hypertension, obesity, heart failure, COPD, we all know they are associated with the worst outcome and also represent risk factor for the development of AKI in COVID-19. These clinical features are characterized by low grade of inflammation and increased immune senescence, although how this impact in the kidney is still unknown, but definitely it is one of the hypotheses. Now the whole pathophysiology is explained on this single slide that we have to deal with hypovolemia. Aggressive diuresis, concern of the aggressive diuresis, we have to consider it. ATM, cytokine storm, glomerular vascular involvement, low perfusion or venous congestion because of high P, direct viral infection of the renal epithelium. So there is a multiple AKI mechanism may exist in the single COVID patient. Now, as we all know, there are different risk factors, but this slide is beautifully described the risk factor among the demographic, risk factor of AKI at admission, and risk factor for AKI during hospitalization. Now you see the top more demographic risk factor: older age, diabetes, hypertension, and CAD. We are all dealing with different patients, and the mortality is high if this patient is of older age and with comorbidities. Another risk factor is high body mass index, CKD, genetic risk factor, immunosuppressed state. Definitely patient with solid organ transplant like renal transplant, we have to take care of this patient because they are very prone to develop AKI. Smoking history. Now, risk factor for AKI at admission. This is very important, especially for the resident, because they have to take history at the time of presentation because the severity of AKI, you have to stratify the severity of AKI. Degree of viremia can be indirectly, we can know from the CT value of the RT-PCR. Respiratory status, non-respiratory organ involvement, that is very important if patient is having diarrhea or something else. Leukocytosis, lymphopenia, elevated markers, hypovolemia or dehydration, rhabdomyolysis, medical exposure of ACE inhibitors or statins or NSAID. So this all should be included in the history. Now, if you've admitted that patient, now comes the risk factor during hospitalization. You just see only the 4 risk factor that has been explained when patient is admitted under our care. Nephrotoxin, that is somewhat important. Medication and contrast exposure. Vasopressor support. Ventilation, high positive and expiratory pressure, and fluid dynamics. We have to manage patient with these 4. Otherwise, this AKI will definitely patient goes into the RRT state and prognosis is bad. Now, risk factor stratification is very important. As I have told you in the previous slide, that patient be stratified for risk of AKI based on their comorbidities, baseline CKD, and demographics. Risk factor for community and hospital acquired AKI, severity of illness, process of care, along with the threshold for admission to the hospital, and ICU should be considered when evaluating patient with COVID-19. Now the epidemiology and diagnosis, the timing of AKI with symptom onset, hospitalization, confirmation of infection, disease severity, level of care should be characterized for appropriate clinical management. Now there is a KDIGO consensus definition. What is KDIGO? It is kidney disease improving global outcomes. Consensus definition for AKI that includes serum creatinine and urine output. This is very important. If your patient is in ICU, it is important to daily monitor serum creatinine and urine output on hourly basis. Using kidney specific tests along with measures of kidney function to characterize clinical presentation, course and outcome of AKI. The role of urinary markers for injury or stress in the diagnosis of COVID-19 remains unclear. Patients with COVID-19 have also been reported to have higher levels of systemic markers like insulin-like growth factor, metalloproteinases, ferritin, C-reactive protein than patients with COVID-19 and normal kidney functions. Now, if we go to the clinical, so we have discussed the pathophysiology, we have discussed risk factors, epidemiology and diagnosis. Now the clinical course. In general, patients with COVID-19 who develop AKI are more likely to be admitted in the ICU. This I will explain later in the subsequent slide with a very good study. In ICU and to require mechanical ventilation and vasopressors than patients who do not develop AKI. Few studies have explored temporal relationship between the onset of severity of SARS infection and development of AKI. A temporal association of COVID-19 AKI with intubation has been observed. However, the extent to which these temporal relationships are related to disease progression, organ crosstalk or associated with interventions such as peri-intubation hemodynamic changes is unclear. Now, these are the clinical and laboratory features which are patient may have asymptomatic urinary abnormalities, glycosuria, microhematuria, acute kidney injury, and patient may have pathological changes of acute tubular necrosis or acute interstitial nephritis, rhabdomyolysis or pigmentary nephropathy, thrombotic microangiopathy because of endothelial dysfunction, proteinuria, and the pathology can be collapsing glomerulopathy, rare reports of the crescentic glomerulonephritis, renal infarction because of microangiopathy. Patient may have renal infarction, and progression of AKI to CKD or ESRD if patient does not recover generally in 4 to 6 weeks of the illness. Available reports indicate that rhabdomyolysis occurs in 7 to 20% of patients with evidence of COVID-19 AKI. Hyperkalemia has been noted in 23% of the patients with COVID-19 AKI and is often associated with metabolic acidosis. Critically ill and had overt AKI had evidence of hematuria and proteinuria. I have discussed the histological evolution showing the collapsing glomerulopathy in proximal, and the mortality of COVID-19 has been reported to between 35 to 80 with rates as high as 75 to 90 among patients requiring RRT. So this is very important. If you are dealing with the AKI patient, you have to monitor that that patient does not require RRT. You have to manage accordingly. Now comes the management part. This is somewhat important. So outline of the management, RRT means the renal replacement therapy, and the renal replacement therapy, there are 3 therapies: hemodialysis, peritoneal dialysis or renal transplant. So here RRT means hemodialysis because we are dealing a COVID-19 patient with hemodialysis. So the non-RRT management of AKI, RRT in AKI, dose of dialysis, modality of the dialysis, timing of the dialysis and vascular access is important. And the most important during this pandemic is the management of scarce and finite resources. So the non-RRT management or non-hemodialysis management with the standard therapy, measurement of the kidney function, serum creatinine and urine output are current the gold standard for evaluation of the kidney. So you have to monitor daily in serum creatinine and hourly urine output in ICU patients. Hemodynamic optimization, this is somewhat important for the renal perfusion, that individualized fluid and hemodynamic management based on dynamic assessment of cardiovascular status. Appropriate volume resuscitation. I have used the word is balanced crystolite that I will explain in the subsequent slide. They are used as the initial management for expansion of intravascular volume in patient at risk or with COVID-19 AKI. This is very important, judicious use of diuretic. It is a common practice all over that if patient is having a decreased urine output, just give Lasix. No, first you have to assess whether this patient is appropriately volume resuscitated or not. Because if suppose patient is having intravascular volume depletion and if you give diuretics, then finally it leads to further decrease in the intravascular volume and it may aggravate AKI. So we have to be very cautious when we are giving diuretic. And second point is that if suppose patient blood pressure is borderline and patient is having high TLC count and BP of 110/70, and if you give diuretic, it further drops to 90 or maybe 100. Then that patient definitely will have aggravated AKI. Glucose management, this is somewhat important because as I've already explained, patient with older age and diabetes, and suppose patient is not even diabetic, then insulin resistance and hypercatabolic state are common in COVID-19 that contribute to hyperglycemia and that further leads to secondary infections. Nephrotoxic agent, this is somewhat very important. Again and again, I am emphasizing on that because NSAIDs, antibiotics, especially aminoglycoside, colistin, proton pump inhibitors, and the contrast agent, you have to be very careful by using these. Because I give you an example, suppose you are dealing with a 70-year-old male, he has a comorbidities of diabetes and hypertension with a serum creatinine of 1.1. You never know. These patients are very prone for to develop AKI. If you consider that his serum creatinine is normal and you give contrast, NSAID liberally and antibiotic, then definitely that patient will end up in AKI. Potassium binding resins is very important because when patient develops AKI and there is a decrease in urine output, his serum potassium start rising. So this potassium binding resins, they control hyperkalemia and helps in delaying dialysis. IV bicarbonate can be given in the metabolic acidosis correction. This study show that if you give a bicarbonate when pH is less than 7.2, then at 28 days there is a decrease in the mortality. Now comes in the non-RRT management, the experimental therapy. First, the antivirals. Evidence that antivirals may reduce the risk of COVID-19 AKI is indirect and limited. Immunomodulatory drugs, hydroxychloroquine, corticosteroid, and tocilizumab, they are drugs that are mentioned to deal with COVID-19, but their effect on the kidney are still not clear. Statin, they inhibit the production of pro-inflammatory cytokines, but it is also under consideration. This is the research is going on this recombinant ACE2 molecule, potential to neutralize SARS and rescue cellular ACE activity. Systemic anticoagulation is important. Thrombi in the renal microcirculation may contribute to development of AKI. Now, what is different about COVID-19 AKI? Generally, patient present with high fever, that is important. They are risk of intravascular volume depletion because of high fever, hypercoagulability, and all lead to reconsideration against an overly fluid restrictive strategy. Why? Now there is a dilemma in the decision because this I have explained that very high fever, intravascular volume depletion, or patient may present with diarrhea. Now, suppose you are dealing with a case of AKI. In AKI patient, definitely there is a decrease in urine output, and suppose that patient has an volume depletion. And if you further restrict the fluid of that patient, it will definitely aggravate AKI. So we have to be very clear whether we have to restrict the fluid or we have to resuscitate this patient with fluids. So this point is very important when you are dealing with AKI. Judicious use of diuretics. Don't go by this that patient urine output is low, just give diuretics. No. First, assess the intravascular volume. Consider renal replacement therapy to maintain fluid homeostasis. This is very important. Timing of the renal replacement therapy is very important. Otherwise, that patient may land up in pulmonary edema also. Now, this is the monitoring. I have a very simple method I have explained here. First, take history, whether you are dealing with a cardiogenic, hypovolemic, or distributing. Physical examination, pallor, diaphoresis, crackles, edema, JVB pulse that has to be assessed. Crude monitoring by BP, SpO2, urine output, and ECG. Non-invasive monitoring by fluid challenge, and invasive monitoring by CVP, TE, and arterial line. So these are the basic things which we have to assess in each and every patient. Balanced crystalloid for volume resuscitation is needed. This is important. Balanced crystalloids. Be wary of the aggressive diuresis on the one arm. Second arm is be wary of the aggressive fluid resuscitation. And trial of high dose loop diuretics if patient is UVU. Please be emphasized on this that loop diuretics to be used if patient is euvolemic or hypervolemic. So first you have, if patient is hypovolemic, please don't use diuretics. Now what is water balanced crystalloid? You just see here in this slide, this is plasma. Now you see the electrolytes of the plasma. So what, and these are the different IV solutions. So these solutions which matches these electrolytes with plasma are known as balanced crystalloids. So important balanced crystalloids are plasma light A and lactated ringer or ringer lactate. These two are considered as balanced crystalloid for the fluid resuscitation in COVID-19 AKI. If you see here, normally we use 0.9% sodium chloride to resuscitate each and every patient. You see here, plasma contains 135 to 145 sodium, but here sodium is 154. Chloride 94 to 111 and chloride is 154 and osmolarity 308. Next slide, I will explain what are the ill effects of sodium chloride if we use in the fluid resuscitation. This is saline. If you see here, this is the most important side effect. Because chloride is high, it leads to hyperchloridemic acidosis. So further, if you are dealing a case of metabolic acidosis, this normal saline will further increase the metabolic acidosis. Other factors that it will increase the inflammation, hypotension, increase the dose of vasopressors, and decrease the microcirculation. So this is very important. If you are dealing with a COVID-19 patient, please use crystalloid, balanced crystalloids of plasma light or lactated ringer. These are the studies, but this SMART study is very important. All are favoring towards balanced crystalloids, none is favoring towards saline. If you see the number of events also, it is less in the balanced crystalloids and more in saline. Now, COVID-19 specific strategies, individualization of the PEEP is important with consideration of its risk and benefit is recommended. Trial of remdesivir and dexamethasone did not reported effect on renal function, although more details may be available in time. But there is one good study which from India only in Mumbai, in which they have shown the safety of remdesivir in patients with acute kidney injury or CKD. What they have concluded that there is no significant abnormality of the renal function attributable to the drug were noted in any of the patients. In conclusion, remdesivir was well tolerated in patients with AKI and CKD, including those on hemodialysis, because in the trial it was when GFR is less than 30, patients are excluded from the study. But in this study, they have included all patients, although long-term side effects to be looked after in the hemodialysis patient, because they have only residual renal function is very low in the hemodialysis patient. This is only the weakness of this study. Otherwise, this is very good study, and the sample size is of around 150 patients. Now comes the renal replacement therapy, that is hemodialysis. So indications same as in any other AKI, like volume overload, respiratory failure, hyperkalemia, metabolic acidosis, uremia, if patient is having nausea, breathlessness, severe oligoinuria. For hemodialysis, you need vascular access, which modality you are using and dose is important. So temporary catheters are usually placed. Catheter length is very important to ensure adequate blood flow and reduce clotting. If you are using a right IGV, length should be between 15 to 20 centimeter, femoral 24 to 30 centimeter, left IGV 20 to 24, and last resort is subclavian, length 20 centimeter, because of chances of thrombosis is high in the subclavian. Use of ultrasound for insertion of vascular access is very important. Timing of RRT, vascular access and modality of acute RRT should be based on patient need, local expertise. Local means if suppose any faculty or resident is not expert in inserting the right IGV or left IGV, then he can use femoral, but he or she has to initiate RRT at the proper time and the availability of the staff and equipment. As COVID-19 often induces a hypercoagulable state, if using CRRT, we suggest use of continuous veno-venous hemodialysis or continuous veno-venous hemodiafiltration to decrease filtration fraction and reduce the risk of circuit clotting. Now, this is somewhat very important if you are dealing a case of AKI, because nutritional status and energy expenditure of patient with COVID-19 and determine strategies to their optimal nutrition management. So protein intake is very important in case of AKI. Patient who are not on hemodialysis, it is 1 gram per kg per day. If patient is on hemodialysis, then 1.2 to 1.3 gram, or on peritoneal dialysis, 1.2 to 1.3 gram per kg per day. And if patient on CRRT, I will explain what is CRRT in subsequent slides, up to 1.7 gram per kg per day, depending on the patient needs. Early enteral feeding is preferred over the parenteral nutrition, and the prone position is not a contraindication for enteral feeding. Now, intermittent hemodialysis, this we all know what is intermittent hemodialysis, commonly used in day-to-day practice for the OPD patients. So dose is 4 to 6 hours twice or thrice weekly. Advantages, it is widely available even at primary healthcare, at the CHC level or district hospitals. Allows treatment of several patients with same machine in a given day. You can dialyze 4 to 5 patients in a 24-hour time. Higher blood flow may reduce risk of clotting. But there are some disadvantages also, like less effective in reaching daily fluid balance goal and lead to exacerbate hemodynamic, because it is a fast process, so it can exacerbate hemodynamic instability. Continuous renal replacement therapy, this is a slow process with an effluent flow rate of 20 to 25 ml per kg per hour. Advantages, it achieves a steady state control of small solutes and acid-base status, because it can be continued up to 48 to 60 hours in a single patient. Least likely to exacerbate hemodynamic instability because it's very slow. Easy to achieve net negative fluid balance and achieve fluid balance targets. Greater hemodynamic stability. But disadvantages, it is a higher end modality. It is available only at higher centers and tertiary care centers. Require 1 machine per patient per day. Requires ICU setting and may require 1:1 nursing ratio. Given the pro-coagulable nature of COVID-19, increased frequency circuit clotting may lead to lower delivered dose. Now the peritoneal dialysis. Peritoneal dialysis means here acute peritoneal dialysis. Advantages: it is widely available, no circuit clotting, no venous access required, but least likely to exacerbate hemodynamic instability. Disadvantages: may be more challenging in patient in prone positions, risk of pericatheter leaks, technical expertise to place catheters. This acute peritoneal dialysis, if CRRT is available, so this acute peritoneal dialysis is replaced by the CRRT. But if in some centers, if CRRT is not available, or even the SLED mode or the slow intermittent hemodialysis is not available, definitely this acute peritoneal dialysis can be life-saving. Now, this is the pathophysiology again. If you see here, moderate to severe disease or multiple organ failure, you see that these inflammatory markers that lead to multiple organ dysfunction, these are circulating mediators, cytokines. So one theory is that if you remove the circulating mediators, cytokines, DAMs from patient, then probably that patient condition will improve. So how to remove the circulating mediator? It can be due to hemoperfusion. We can remove it for the cytokine removal. So inflammatory cytokines, damp and pathogen-associated molecular pattern, including endotoxins, SARS particles, particularly contribute to development of multiple organ failure. And EBV techniques have been shown to remove cytokines, damp and PAMP, including endotoxin and circulating viral particles, but is not yet very much proven or effective. Now, the most important part is how to manage the plan, because we have limited staff, there is a supply chain and the machine use. This is very important. So background is that the RRT is commonly required life support tool for critically ill ICU patients. 15 to 30% ICU patients require RRT. Multiple method to provide RRT. All method is effective when used appropriately. So in this background, we have a challenge. RRT is a finite resource due to limitation in machines, supply, personnel, trained personnel is very important, and search, because this is a pandemic, we never know. Suppose we have dialyzed 10 patients in October or 15 patients in October, but we never know how many patients will come in December or January, because we are dealing with the pandemic and surge will come at any time. So we have to prepare for that. This is a very good diagram showing that if there is a pandemic and disaster, there is a stage of preparatory, response and crisis. So we have to act accordingly and to maintain our machines and staff ready for the surge. At present, hemodialysis and CRRT facility in suspect ward, COVID ward and COVID ICUs are available bedside for 24 hours at AIIMS Jodhpur. Now, need for dialysis. How we decide that this patient needs dialysis or not? There is a risk assessment. On the basis of that risk assessment, this patient needs dialysis on emergency basis, or it can be delayed for some time. After discussion of that, if suppose there are 10 patients we have to dialyze in a day, so we have to assess that which patient to be dialyzed earlier and which patient can be dialyzed in the evening shift or the night shift. And then finally, for the decision of the RRT, that which modality is to be used in the particular patient. Now, there is a very good study. There is a Northwell group in the New York. Now you see here what the data is saying. If patient is no AKI, although number is more, but expired percentage is very low, 5.6%. But if patient is having AKI, although number is less, but you see the 34.8% patient expired and 39% patients are still in the hospital, whereas as compared to this, only 14% patients are in the hospital. So if patient is developing AKI, definitely prognosis is bad in case of COVID-19. Now the proportion of patients with AKI by requirement of invasive mechanical, as you see, required invasive mechanical ventilation from 1190 patient, 89% of patients have AKI. So there is this is a temporal relation which has been shown by this Northwell group. So it is very important when we are dealing with patient in the ICU who may require invasive ventilation or vasopressor support. Now this is our own data. You just see here, generally this hemodialysis started in the July. Earlier AKI cases was very low. And if you see here, the number of patients is 8, 12 and the HD session they require. But this is somewhat important. In August, September and October, almost patient number remains the same. But in November, there is sudden surge. As you see this 12, 14 and 16 patients. But in only 15 days of November, we have dialyzed 15 patients. This is somewhat important. Probably we are dealing with a third wave. Now, this is the data. This ICU patient, approximately 1,000 patients were there in ICU, and ward is 2,000 till now, because 3,500 patients were admitted at AIMS since this COVID-19. Out of this non-AKI 892 patient, AKI was observed in 158, 15% of the patient. And among these 158 patients, AKI required in 65 patients, that is 41.13%. And definitely mortality was observed in 35%, that is 53.84%. This is something which is scary, and we have to take care of this. Now, to conclude my talk, kidney involvement following SARS infection is more common than initially thought and is associated with the morbidity and mortality. The pathophysiology of COVID-19 AKI is probably multifactorial. Available evidence suggests an incidence of over 20% in hospitalized patients. High incidence of AKI in COVID-19, especially in critically ill patients. Creative ways to minimize nursing exposure without compromising patient safety. And management of finite resources is critical to provide RRT to as many as people as possible. So I must say this is a deadly disease, and definitely I'm using the word, we have to respect this virus and we have to follow jab tak dawai nahi tab tak dhilai nahi. Thank you.
In the questions, we have first queries there from Dr. Gautam. In COVID positive patients, is any form of renal replacement therapy better than the other? So it is a matter of choice regarding depending upon what is the hemodynamic status of the patient. Like if the patient is presenting with hypotension or the patient is requiring multiple inotrope support, then modalities which are helpful will take into consideration the hemodynamic fluctuations which the patient can encounter during the therapy. So in such a situation, the patients are given SLED, which is low efficiency dialysis, or continuous renal replacement therapy, in which we opt for continuous venovenous hemodialysis modality for the patients. And in resource restricted patients, for example, patients who are being exposed to an area where CRRT facility is not available or SLED is not available, then acute peritoneal dialysis can be instituted in those patients, which also takes care of hemodynamic fluctuations of the patients, as well as it also helps in slow and gradual removal of the metabolic waste and improvement in uremic encephalopathy in these patients. The next question is by Dr. Vijay, that intravascular volume, since it is so important or crucial and volume assessment is so important in COVID, any studies are using stroke volume variation to guide the fluid therapy? If no studies, what is your opinion? So intravascular volume assessment is very crucial, because either we overhydrate the patient or we underhydrate the patient, both have their own risk. So maintaining the euvolemic status is very crucial in the management of these patients. So assessment of the volume would be first as a clinical indication, that is the JVP, the hydration status, which can be clinical assessment which can be done. Second is assessment of the hemodynamic status, taking into consideration the mean arterial pressure the patient is having, which should be optimum for the hydration status or for the volume supplementation of the various organs being perfused with that. Third important thing is the introduction of ultrasound in the intensive care setting, where ultrasound can be helpful in assessing the volume status in the lungs, especially because auscultation would be limited in these patients on account of the setting of pneumonias in these patients. So auscultation would not guide us. So here lung ultrasound has come up in a good way, and use of lung ultrasound, which is effective in showing the fluid in the fissure, as well as it is also helpful in demonstrating the interstitial edema, especially in the basal lobes of the lungs, demonstrating the classical comet sign which can be seen. The fourth thing is there's also utilization of IVC status and deep inspiration in the patient, like the absence or presence of collapse status in that situation. Definitely, echo can also help us in knowing about the stroke volume in these patients, but the studies which are being used are used as far as the other criteria, like in patients with shock, presenting with ARDS, patients having sepsis with ARDS and shock. In those patients, stroke volume has been used. But right now, regarding in the patients with COVID status, we do not have delineated therapies that the stroke volume, definitive stroke volume estimation and its variation to guide the fluid therapy in these patients. So, yes, safety of Dr. Ankur has asked about safety of remdesivir in renal transplant patients. Yes, it is very, very important that remdesivir is the drug which can restrict or it can stop the replication of the virus, which is the only drug which is right now available. Rest steroids which are given is mainly for restricting the severe inflammatory status or the epithelial damage on account of severe inflammatory status which is or milieu which is there in these patients. Now, as far as remdesivir is concerned, the remdesivir needs it is the drug literature says that it has to be used. It is not indicated in patients who have a GFR which is less than 30 ml per minute. And the other thing is that the vehicle which is used to administer this drug, the constituent which is there with this drug, is the sulfobutyl ether cyclodextrin, which is there, beta cyclodextrin, which is there. It has a pertinent renal toxicity in these patients. So, but that is taken into consideration whether the drug is being administered in a lyophilized prepared form or it is given in a liquid form. Those patients who are being given lyophilized prepared form, there the dose of beta cyclodextrin is high and it can cause injury to the patient. Second thing is, the important thing is that one has to monitor the liver function in these patients because it is also contraindicated if the liver dysfunction is present, especially if the upper limit of normal of the transaminases is more than 5 times the normal upper limit of normal. So those are the things which have to be taken into consideration, and toxicity which has been shown in these patients has been direct mitochondrial injury in the proximal convolutular cells also. But that the dose which was being administered was very high. The dose which we gave in these patients and the duration for which this drug is being administered to the patients is for 5 days. First day we gave 200 milligram BD and then subsequently the next 4 days 100 milligram OD. So that dose has not been associated significantly with toxicity. But in patients with renal transplantation, it has, right till now, as per the literature is available, it has not shown any significant interaction with the immunosuppressants which are used. Secondly, in patients who have a GFR which is more than 30 ml per minute, it can be used safely to restrict or to prevent the multiplicative stage of the virus. And those patients who have a GFR which is less than 30 ml per minute to 15 ml per minute, these patients can be given remdesivir, but the risk-benefit ratio has to be weighed in these patients before administration. And the other thing is one have to look into consideration what is the transaminases levels which are also available. As far as the patients who have end-stage kidney disease who are on dialysis, they can be administered remdesivir because there is end-stage kidney disease. Patients are already on hemodialysis for a long duration of time, CKD on maintenance hemodialysis, because almost 50% of the drug is cleared. The beta cyclodextrin molecule is cleared with the hemodialysis procedure in these patients. So Dr. Santosh has asked regarding modification of immunosuppressants in renal transplant patients, and especially the patients they come with and they are positive for COVID positive in this scenario. So one has to take into consideration that in these patients, immunosuppressant modification, as it has been mentioned by the European Society guidelines as well as by the American guidelines, which have been mentioned, and the Indian Society of Organ Transplant, they have recommended that patients who are presenting with active viral replication the first 7 days, one has to look for lymphopenia in these patients. If lymphopenia is present, then one has to do away with in the immunosuppressant protocols, we use 3 drugs. One is the CNIs, that is calcineurin inhibitors, which we use. The other is the anti-proliferative agents like mycophenolate mofetil or azathioprine, and the third is the steroids. So you have to do an upscaling of the steroids in these patients. You have to increase the dose of the steroids. And the preferable would be to convert the patients on prednisolone to methylprednisolone because it has a short half-life and very quick onset of action. And a higher dose is being given in these patients. Secondly, the anti-proliferative agents, if lymphopenia is present, then one has to do away with azathioprine and mycophenolate mofetil. The protocol says that if there is a mild AKI in these patients, or the patients are present with mild COVID presentation, then halving of the dose of mycophenolate mofetil can help. For example, if the patient is on 720 milligram BD of MPA, then it can be reduced to 360 milligram BD. with persistence of lymphopenia, it can be removed from the treatment modality. And if still it doesn't favor the outcome in the patient, then stepwise modification further in the dose of CNIs, that is, CNI dose can be halved in these patients. We do not have a definitive consensus guidelines, but this is the protocol which is being followed in renal transplant patients because of their increased tendency being immunosuppressed to get a severe manifestation of the underlying disease of COVID infection in these patients. Do you have any other queries for the present talk?
Thank you very much to all for attending this session. Thank you from the Department of Nephrology. Thank you.